And so, maybe a good place to start this discussion off is to really just define insulin resistance to get everyone on the same page.
Yeah.
Could you give us a definition?
Yeah. Yeah. So I do. I certainly make the case that in my book and as a professional career, that insulin resistance is at the root of certainly all metabolic disease, but also virtually every chronic disease as well. So insulin resistance is this state in the body where it's really a combination of two phenomena, where one is that insulin isn't working the same way at certain cells in the body, and then two, insulin levels are elevated. So the person is experiencing a hyperinsulinemia. And that first point is important with this sort of selective response. Some of the body's cells aren't responding the same way they used to insulin. And what's important there in that idea is that literally every single cell in the body has insulin receptors. So in other words, every cell in the body is built to respond to insulin in some way. And of course, there are so many different types of cells. It's no surprise that each different cell will respond to insulin in a different way, doing something different. But with insulin resistance, again, although I've said this now a couple times, insulin isn't working the same way at some of these cells. Something is compromised in what insulin's trying to do. And then when we combine that with the fact that insulin levels are much higher than normal, it really starts to paint the full picture, because the body's cells that are still responding to insulin perfectly well, they're now responding to too much insulin. And so what was a normal response before is now a hyperactive response. And the combination of this sort of selective responsiveness is really what is at the heart of explaining how insulin resistance is so fundamental to so many diseases.
Absolutely. And if we, then when we think about obviously type 2 diabetes, we think insulin resistance, so all the way to the end of the spectrum. And of course, today, unfortunately, we've got 2/3 of the populations, and whether it's Canada, the US, the UK, classified as overweight or obese. And so, at what point in this spectrum does this start to take root? And is it impacting anyone who's struggling with weight gain?
Yeah. Yes, absolutely. If someone's starting to gain weight, now that alone isn't going to be a distinguishing factor, because there are people who can actually get fat and stay very insulin sensitive. So obesity itself, even obesity, isn't necessarily going to be a slam dunk identifier, although it very, very often will. But if someone is overweight, if they have more fat than they know they should, and they have another problem like elevated triglycerides in their blood or elevated blood pressure, or even slightly elevated glucose, then that starts to become a concern. When you combine that excess weight with some other evidence of poor health, then it's a much more definitive opportunity to diagnose the problem as insulin resistance. And of course, to flip that around, if someone has elevated blood pressure and steadily climbing glucose levels, or infertility, or fatty liver disease, or many other problems, and again, that can happen in the absence of overt weight gain. The person may look lean, but in that specific instance, they actually may be well on their way to having profound insulin resistance. You just wouldn't know it by looking at them. And this becomes particularly problematic as we try to view insulin resistance in the global context that it deserves. Some ethnicities, like those particularly of Asian ethnicities, Chinese, they will not show their weight gain very quickly or very readily. In other words, a very modest increase in weight gain on a say a Chinese man or a man of Chinese ethnicity background, it will start to impact his metabolic health much sooner than, say, a Caucasian European, like the countries you mentioned, like UK, Canada, US. So different ethnicities are more sensitive to fat gain than others, and so we, even though the outset of this moment of this conversation, you asked sort of about weight gain, it can happen in the absence of weight gain, so or obvious weight gain. And so we can't always peg the diagnosis to just how fat a person appears to be.
For sure. And, we talk about these chronic diseases. heart disease, obviously the number one killer, and a strong link there to insulin resistance. Can you talk about how insulin resistance starts to influence our cardiovascular health?
Yeah, that is the low-hanging fruit. So I like that you're starting with that as one of the key concepts, because most people with insulin resistance will die of heart disease. That's typically what's going to get them in the end. It's not the insulin resistance per se; it's going to be the heart disease.
Mm-hmm.
The one of the strongest risk factors for heart disease is blood pressure. If someone has hypertension, they are several times more likely to have a cardiovascular event like a heart attack and subsequently die from that heart attack. Insulin has a powerful control over what the body does with body volume and with the diameter of blood vessels. So generally, it's effective to look at blood pressure through through two lenses. One is blood volume, and the other is the size of the blood vessels, or the diameter. Imagine if we were looking down the length of a tube. Is the tube wider or have a higher diameter, or is it narrower? So let's start with the first concept of blood volume. When insulin is elevated, as it is with insulin resistance, it increases another hormone. It forces this other hormone called aldosterone to be elevated. It won't let it go down, even if it wants to. And when aldosterone is elevated, aldosterone signals to the kidneys to keep in salt and water. Mm-hmm. And so even though the kidneys want to be getting rid of this as blood pressure climbs, normally as blood pressure is going up, aldosterone would go down, allowing the kidneys to get rid of these things, but insulin won't let it happen. So the kidneys are continuing to reabsorb salt and water and keep the blood volume higher than it would normally be. And of course, as volume goes up, pressure goes up. Just imagine like we're filling a balloon with more water. That's what we're forcing in this situation. And then that problem is compounded by the second. Namely the diameter of the blood vessels. When insulin is working well, it will flow through blood vessels and tell those blood vessels to dilate. So they will get bigger. And of course, as that gets bigger, the volume of the blood vessel, the diameter, the pressure would go down. Yep. But it doesn't happen. As those blood vessels become insulin resistant, insulin can no longer induce that vasodilation, that dilation of the blood vessels, and thus a blood vessel that should be dilating stays narrower or stays more constricted. That is evidence of the insulin resistance. So we have those two combined really create the fundamental cause of hypertension in almost all instances of hypertension. That's why I mentioned that one at the beginning of our discussion. If someone has high blood pressure, it is extremely likely to be a result of insulin resistance. Now, not always. Like you can take a perfectly healthy person and they may have elevated blood pressure in a day, and that is very often a result of poor sleep. But if we're talking about chronic elevated blood pressure, chronic true hypertension, that is very often a result of insulin resistance.
And if we stay on this area here and talk about, we've got this population or client who's overweight and has high blood pressure, and if we think of blood glucose levels being persistently and chronically elevated as well, how does that then tie into just the quality of those vessels in terms of, if we're talking inflammation, oxidative stress, how does that fit into the picture?
Yeah. So when we do combine the insulin resistance with the elevated glucose, like we start to see, of course, in type 2 diabetes, now we've added another pathological dimension. So elevated glucose does cause small vessel damage and even perhaps large vessel damage, which contributes to the poor blood flow and the subsequent ulcers that we see in type 2 diabetes. And there's likely two mechanisms. You'd mentioned inflammation, and that's very appropriate. When glucose is elevated in the blood, it can combine with amino acids in the blood and create molecules called advanced glycation end products, or AGE, or AGEs. And these AGEs, advanced glycation end products, will then bind receptors on the blood vessel wall cells, these endothelial cells, stimulating or activating inflammation literally in the wall of the blood vessel. So that's a very known phenomenon. And then a second one is independent of inflammation, but it's nevertheless dangerous to the blood vessels. When glucose is chronically elevated, the cell essentially is pulling in more glucose than it needs to metabolize. And when you look at these blood cells, they don't really have a capacity to store glucose as glycogen like the muscle or the liver does. And so some of this glucose is converted into a molecule called sorbitol. And sorbitol sounds familiar because it's something that we will put in as a sweetener in certain foods. Part of the reason it's a non-caloric sweetener is that it is membrane impermeable. It will not pass across membranes, which is why you eat it and it stays in your guts. It will not get absorbed into your body. Well, the same thing becomes a problem in this case. As the glucose is pulled into the endothelial cells along the blood vessels, it converts into sorbitol within the cell. And as you have more and more sorbitol accumulating within a cell, it creates something called an osmotic gradient, or basically it starts forcing water into the cell, and the cells start to swell, like literally physically starts to swell to the point that it can actually burst, as if you were filling a water balloon to full and burst. And that can cause damage of those small blood vessels like the capillaries as well.